Hello and welcome. The number of COVID-19 cases in India are now flattening out and obviously at a much, much lower level. Just to put things in context, in the middle of September when India was peaking, we were at about 97,000 cases a day and at about 1,300 deaths a day. Today we are at about 12,000 cases a day and about 120 deaths. Many of those cases and deaths are actually in a handful of states like Maharashtra, Kerala and others. Large parts of India, actually, the disease almost seems to have gone away. The reasons, of course, are still being investigated. But let's try and understand what we are seeing today on ground, particularly on the front lines in the hospitals among specialists, in order to understand how this disease is spreading today, through whom it is spreading, and are we seeing any variations and differences in the in either the symptoms or the way cases are being presented at the hospitals, particularly in cities like Mumbai, which is part of Maharashtra, which has at this point still a higher case count compared to other states in the country, and then maybe understand how the disease itself is spreading and is it really slowing down or is it likely to keep slowing down as we are hoping it will. To discuss that, I'm joined by Dr. Om Shrivastav, consultant infectious diseases specialist at Jaslok Hospital in South Mumbai. I'm also joined by Dr. Kiran Shetty, consultant critical care medicine at the Kokilaben Dhirubhai Ambani Hospital in North Mumbai. Dr. Shetty is joining us from the hospital. Thank you both for joining me. Dr. Shrivastav, let me begin with you. So the first question and the key question is, what are you seeing different in the way the disease is presenting itself today as compared to even 3 months ago or 6 months ago?
So, thank you, Govind, and good evening to everybody. What is different now? What is different now is, well, as you already rightly pointed out, that the total number of people who are getting infected and requiring hospitalization is lesser. It's much lesser. It's down to a trickle. They're still there, and they still need to go to ICU, but they're nowhere close to the total number that you were seeing just about a couple of months ago. That is one. The total people who are needing to come to hospitals, they are a little bit sicker. And this has probably got to do with the fact that the strain that came from the UK is a little more infective. And for some reason, people needing healthcare are more. Right now, they appear to be more. They don't necessarily appear to be people who are all going to be needing ventilators, but they are people who are going to be requiring healthcare either inside the hospital or more stringently in the community. What is more interesting in both these aspects is that the numbers have dwindled, but not the total number of people who are getting sick. Now, this may actually have to do with the total amount of infectivity in the new strain that has been circulating ever since the time it has come from the UK to India. And so the total number of people getting infected either through travel or by close proximity, that is still significant. That can't be trivialized. So those things are different. Whether they are going to stay like this or they are going to become different, as time goes on, we will know in another few months' time or maybe even longer. We are nowhere close to where the numbers as you've already rightly pointed out, where it was about 97, 98,000 per day. It is down to between 10 and 12,000 per day right now. And hopefully it will stay that way and probably even get lesser and lesser. So It is a place to be watched carefully. I don't think that anybody is in a position to make a prediction as to how the virus is going to behave from here. But certainly people who are in the healthcare system will be watching it very carefully. And people who are in the public health system will be watching this even more carefully. So I would say that this time, maybe in about 3 months or 2 months, we will have a much better idea as to where the virus is heading.
Right, and you mentioned exposure to people who've come from abroad. Now that was exactly the case in April or March, second half of March, April, that the disease clearly, or the virus clearly came from overseas, as it did elsewhere in the world as well. So when you look at some of the cases today, are you able to see where people are getting infected as opposed to, let's say, a few months ago, where it was clear that you could be anywhere in the city of Mumbai or Delhi or Kolkata that you could be infected?
Yeah, I think that that part is also quite clear. Although I don't think that I'm at liberty to discuss exactly where we think it's coming from, because it is data that should be shared, will be shared by the government of Maharashtra. I can share with you that it is coming from much smaller pockets now than what it was, in March or April of 2020. But I think that let that information come through the
Right.
right channel in government of
Okay.
Maharashtra.
Right. Okay. Dr. Shetty, let me come to you. So how are you seeing it from your vantage point as a critical care specialist? I mean, in the progression of the disease and its behavior, particularly in the last few months?
Yeah. So I would completely agree with Dr. Om that yes, I mean it's too early to actually comment because as a trend, I mean we've sort of followed the West by about 2-3 months. So I mean it's too early to say that probably because the numbers have dropped, it will stay that way. It's too early to say that. But in terms of intensive care, I would say that yes, the number of cases have dropped drastically, and that's probably because of our demographics. Probably younger patients are not really manifesting with such severe symptoms, and the real sick patients that are coming are the ones who are elderly. And so, in terms of the comorbidities or in terms of the illnesses which predispose to severity of the disease, I don't think that has changed. So we still are getting those sick ones who have the chronic kidney disease or the obesity or the diabetic. So we're still getting those ones. But yes, the numbers have definitely dropped, and I think partly it's because of the demographics, and probably younger patients are probably tolerating it better at this point. That's what we've seen. I
So,
mean, our ICU occupancies have dropped to 1/3 from what it was when we were at our peak.
right. So the patients who are coming today, and you did say comorbidities, I mean, is it the same level of comorbidities? Are these patients who are even more vulnerable than those who came even 3 or 4 months ago, or is there perhaps no difference?
I don't think so. There is any variation in that. I mean, it's very difficult to segregate very clearly whether those patients were sicker or whether the patients who are coming in now are sicker. I think it's more or less the same. I don't think there's too much change with that. At least the ones we're
So
seeing in
if you were
intensive
to
care.
then speculate a little bit, where would you think most of the patients that you're encountering now are getting infected, and how are they contracting the disease?
No, I mean, in a sense, I mean, I don't think we can really pinpoint as to where they are getting it as such. Okay. Because see, these patients were always vulnerable to start off with. I mean, what I'm trying to say is probably the second set of patients who were probably not that sick used to end up in our ICUs. Those are the patients who are not really coming. The real sick ones are still coming in. So I don't think there's a particular area from which they are coming to.
Right, and if you look at, I mean, those who are not coming, in the sense that obviously a lot of people are not getting sick, or even if they're contracting it, but not contracting it at all. Now, if you were to look at the seroprevalence studies that are now emerging, it's clear that very large numbers of people in this country have already contracted the disease.
Yes.
And I'm going to come to Dr. Srivastav on this as well. But any thoughts on how and why this has happened?
I would think partly it's also to do with the bit of awareness that has gone, and so so they reach the hospital much earlier, and so they don't necessarily, and at least I can talk from a critical care perspective, they don't really end up in the critical care because they take medical attention much earlier, and that may be one of the real reasons. Because I mean we've had a lot of young patients earlier coming in with symptoms where they've actually sat at home with problems and then coming in at day 10, day 12. So that obviously then they end up in the ICU and then they run the cost, but that's not happening anymore. So probably seeking early medical attention also has helped.
Right, and the nature of treatment, the medicines that you're using or the approach that you're using, is that changed in any way in the last 3 or 4 months?
It's not really changed as such, but I think we fine-tuned as to who requires those. So institution of steroids, institution of remdesivir, or something called as tocilizumab, which I think most people have largely given up now, and plasma for the matter. So fine-tuning of those treatments, when to give what, when to do CT scans. So those things have really, so we've got, I mean, each hospital I think now has well-set protocols when a patient comes in. So that also seems to have helped, because then lesser amount of patients are really getting sicker. Even if they end up in hospital, they are on 1 or 2 liters and they tend to get better.
Right. Dr. Srivastav, if you look at the seroprevalence studies, we are clearly seeing that many people have already contracted COVID-19. As someone told me, an economist actually, saying that this virus has already swept through the country. What's your sense? I mean, is it also that we have now developed fairly high levels of immunity or almost herd immunity, which is why you're not getting cases?
So I'd like to make a couple of points about herd immunity and antibody levels, right? When you say that X number of people are going to be having herd immunity, that means that 2/3 of the population in the general population should be having antibodies. Now, what are these antibodies? The antibody that you're looking for is what is called the neutralizing antibody. That's important because it's not just simply a matter of doing a blood test and saying that yes, I've done the IgG levels of the antibodies and that is positive. And in doing that, I find that there is no problem. It must be what is called a neutralizing antibody, and that this neutralizing antibody needs to be in the patient system for longer than between 2 and 3 months. If it is less than that, then it is going to be conferring no protection to the patient. So, it is not enough to say that, yes, I've looked for antibodies and the antibodies are there. It's important to find out how long these antibodies are going to be lasting. I think that, before we make any comment about immunity is here, we'll probably need to give it some time. We'll probably need to wait it out and see as to where the story is going to be unfolding in the next maybe 6 months' time or 1 year's time, or maybe even 2 or 3 or 5 years' time. Because this is a viral infection. COVID-19 is a viral infection that has swept the whole globe, the whole planet. And we know it for less than a year's time. So, for anybody to say, yes, I know enough about COVID, it would have to be a very brave person, I wouldn't venture to be in that position because just about everything that we know now is going to be unlearned tomorrow morning. Tomorrow morning, there's going to be a fresh set of evidence that will tell us that what you thought you knew yesterday evening, on Friday evening, is now going to be junked because this is the evidence that we have right now. You see, so I would wait. I really would wait. I think that there is some evidence that is going to be coming our way every day. But I don't think we know enough to say that, yes, this is how the virus is going to be behaving.
Right.
And exactly what's happening.
Right. And and the reason I'm asking this is, I mean, one is, let's say, a certain degree of immunity that there is in the system. At least that's what the seroprevalence studies are saying. At another level, clearly the masking, the adherence to the safety standards is high, or at least seems to be high. So my question is really, which is working more, or is it both that are working to keep the levels at these low levels that we are seeing today?
So if you were to pick any one measure, Govind, it would have to be the masking. Okay. If you look at what has worked in the last 1 year's time or 11 months' time, or wherever you want to say, is the index where COVID started. It has to be the masking. Of course, it's also the social distancing and the hand wash. But if you were to pick one feature of what has saved lives day in and day out for the last 10, 12 months, it would have to be the masking. So I think that, I'll come back to the point I was making, that it must be evaluated in the context of how much information has come our way. So I'll tell you again, in a very, very relative kind of context, when we started learning about this in the month of, say July, August of last year, we would say that the people who are at the highest risk are going to be people who got this condition or that condition, or cancer, or whatever else you want to look at the evidence at that time. We know now in the last about 3 or 4 months, maybe even 5 months, that the people who are at the maximal risk are people who are the elderly and people who are the obese. A body mass index of more than 29 is going to put you into the highest risk category of not just getting COVID, but also getting complications. So you see, we didn't think this was the case when we started evaluating the risk factors for COVID. And so I say again that, yes, of course, we are learning every day, but we know that there are some things that are probably going to be the benchmarks of who are going to get complications in COVID. And of these two categories needs to be watched the most carefully.
Right. Okay, let me come to the mutation that we've already talked about and you've referenced. Dr. Shetty, are you getting a sense that some of the cases that you're now seeing are those who have had the new mutations, either from the UK or South Africa or somewhere else? And if so, how is it playing out? And is it playing out any differently?
To be honest, I'll say clinically, at least in the critical care setup, I don't think we've seen anyone behave differently as such. I mean, we've had more or less the same sort of trajectory with cases. So, I mean, it'll be very difficult to differentiate clinically whether this is a different strain. But as I think Dr. Om mentioned right at the onset, probably it's just a more infectious strain doesn't necessarily mean that the severity of the illness really changes, or probably it is, for all you know, it may be less severe. But as I told you, I don't think clinically you can really pinpoint and say that this is probably the mutant strain and this is probably the original strain. I don't think we've reached that point yet. But probably it's just that the numbers that we've seen with the new strain, we haven't reached that point.
Right, and that question has been answered by specialists elsewhere in the world, and I'm trying to get an India answer now. That basically this is more infectious doesn't mean it is more clinically dangerous. Dr. Shrivastav, your views?
Yeah. So again, if you look at what we know now and the strain that has come out of UK and South Africa and parts of Europe, there are only two major parts from where the mutation has been established. Okay, there is a stop codon mutation which is at 63, 64, and another mutation which is also a stop codon which is at 143, 144. What that means, whether you are going to be having to do the whole genomic sequencing, and what genomic sequencing do we have before these mutations have been described. If you don't have it, then you are simply struggling with what evidence is brand new. But unless you have the genomic sequencing of the virus before these mutations were described, you are not going to be achieving anything. So, I think that information needs to be viewed into the context of what else was available before you can say that, yes, this is the information which is relevant now. We must be in a position where we are going to be doing, genomic sequencing. And how many genomic sequencing are going to be important? I would say several hundreds of thousands. That is going to be our benchmark for taking the understanding of the virus forward. This is an RNA virus. This is not the first outbreak. It's not going to be the last outbreak. If you look at the last 10 years' time and think about where the total number of outbreaks that have come in the last 10 years' time, you'll know that they have all come from this family or identical families. So to do the genomic sequencing is something that augurs well for our own understanding, our own knowledge. And in doing that, we are only going to be equipping ourselves in ensuring that we have the information that we need for maybe the next 5 years, 10 years, 15, 20 years. We need to plan accordingly, because COVID, like I say again, COVID is not the first outbreak. It's not going to be the last outbreak. But unless we prepare in looking at and understanding a genome sequencing and what might have changed in the next outbreak, we are simply going to be, making educated guesses, which is what it is, an educated guess. It means nothing in the scientific community. It means nothing. You need to validate what you're saying in a platform where people will say that, yes, I accept the point you're making scientifically, and I'm going to take this forward. Unless that happens, everything remains exactly what I just said. It's an educated guess. Govind.
Right. Dr. Shetty, you did say that, the number of cases, COVID, I'm assuming you meant COVID cases have come down to a third at the critical care or intensive care level. Are you seeing other diseases, conditions now rise and is there any correlation between the lockdown and that period to what you're seeing now?
Not really. I mean, to be honest, our ICUs have been as full as they were earlier. So I don't see that there has been a dip or a rise in other cases. So I personally don't see the case. I mean, probably there was this apprehension. So people who would sort of manage with certain symptoms at home are now coming up. Probably that's the only difference after this lockdown has eased up. But I don't think that the other cases. The only thing that I would want to point out from our perspective is, and surprisingly so, I mean, I don't know whether it is related to this virus, or I read an article somewhere that this is the fight between the viruses and humans are collateral damage, because we've hardly seen any dengue this year. We've hardly seen any. So, I mean, that's very surprising. That could probably be boiled down to less of construction work happening, less of stagnant water. Probably those are the reasons. But I mean, in fact, so in fact, the tropical disease, the main tropical disease like malaria and dengue, we've hardly seen the post monsoon period at all. So that's very surprising. So that would be a takeaway from it.
Right, and when it comes to the other conditions like diabetes and obesity and so on, I mean obviously these are not specifically linked to COVID-19 or this period the last year that has gone by. But are there any other changes that you've seen? Have people changed their lifestyle? Are you seeing less cases perhaps?
I really don't think so. I mean, at least not in the critical care setup. I mean, see, it's difficult. I mean, if you are obese, I mean, it's difficult to turn around in about 2 months' time. All right.
Right.
So I don't think there has been any change in terms of the type of patients that we've seen apart from COVID. I think it's more or less the same.
Right. Okay, Dr. Shrivastav, let me, last couple of questions. As you look ahead now, we are where we are. People are feeling confident. The economy is looking up. The stock markets are doing well. And, this is also the time when people may start, taking things easy. Your advice to those who are watching and will watch on how to deal with and treat this virus, treat as in not as a doctor, but as an individual. And going forward, what else should we be looking out for?
So I think on a lighter note, Govind, the one thing that has definitely happened in the last maybe month or a couple of months is that people have all turned into teenagers. Everybody wants to party and party hard as if there is no tomorrow morning, right? That's the one thing that has definitely happened in the time post-COVID. I think that there is something to be said about making sure that you do not let down your guard and that you are watching that at least the mask is some part of your it's a way of life now. Please don't drop that. Also, don't treat yourself and also don't disregard symptoms. Whatever symptoms that you may have, howsoever trivial it may appear at that time, do not make the mistake of treating yourself because these are viruses that may be trivial to start with, but beyond a point, they will become nasty, aggressive. They may also become viruses that may be requiring treatment, not inside your own homes, but in hospitals or parts of hospitals where it is just not welcome. So I think that it is important to make a point that you do not let your guard down. Make sure you are wearing your mask. Make sure you're taking your medication. By all means, take all the other vaccines that you would have taken or not taken in these many years. Take your influenza vaccines. Take all the other vaccines that you are meant to be taking. Please talk to your doctor. And please do your blood tests at least once in 6 months or once in a year. Make sure that somebody is watching those things. And as fit and as good a lifestyle that you can lead is what should be your
right.
target for not just the foreseeable future, but for the next 3, 5 years, 8 years, 10 years, whatever time you want to be planning.
Right, and you mentioned vaccines, and that was really my last question. People are getting vaccinated, doctors, frontline workers, maybe both of you are also have already got vaccinated or will do if not. So how does one, can one let one's guard down while with vaccinated people, or if I am vaccinated, then should I stop wearing a mask?
Well, you can't really, because we know one thing for sure is that vaccine or COVID or not, you will keep shedding the virus, and that you may not have any idea that you're actually shedding the virus. So I don't think that getting COVID or taking the vaccine is something should let your guard down, because that strain that is circulating or the strain that is in your system may not be the strain that is covered by the vaccine. So by all means, you must take the vaccine, and you must take the vaccine that is recommended by wherever, whether it's the BMC or your doctor, or if you're a healthcare worker, of course, you will already be called. If you're not a healthcare worker, then you're about to be called. So yes, by all means, keep a very close eye. Take the vaccine, but do not let your guard down. There is just no way that you can say that, yes, I've had the vaccine or I've had the COVID infection and I'm safe now. That is one way to ensure that you have made one mistake that may be fatal. I don't mind saying it in that many words. Not let your guard.
Right. And that's indeed is the moral of the story. Don't let your guard down. We've fought hard and smart all this while, and let's not lose the efforts and the gains that we've made. On that note, Dr. Om Shrivastav and Dr. Kiran Shetty, thank you so much for joining me and sharing your thoughts.
Thank you.